I remember after our first appointment, my sister walked out of the office, and I think for the first time she was able to exhale because she felt that there was, not finally, but there was a team of people to support her as well as to support me, but took time to understand exactly what you said, what's going on in her life, what was going on in my family with my kids, how are they doing, how is her family doing during all of this, which was a critical turning point. Because I think when people feel heard, they can do better because then they're no longer afraid to ask. And I think sometimes when a patient is in the midst of a serious illness and you're with all the ologists, oncologists, neurologists, or every ologist there is, everything is so scientific and you're being thrown so much information that there's no way a lay person who hasn't gone through 8 years of medicine can really comprehend in this short amount of time. Palliative care took that time to sit with us. My first visit, I think they listened to my heart, but they did just the brief assessment, but it really was about getting to know me and getting to know what was going on in the big picture, which was dynamic.
You said something that I think should be underlined, which is feeling heard. And because of the pressures of time, and doctors are always behind, and they always have a waiting room full of patients, and they're looking at their watch, and they're documenting on the electronic medical record. The last thing the patient and the family feel is that they have a right to take more time by expressing their concerns, asking their questions, and talking. And yet, if people do not feel heard, we can't take good care of them because we don't know what the issues are. So it's a circle. And the time pressures in medicine in some ways are our worst enemy because they make it very difficult to take the time to hear the patient and the family. And yet, if we don't hear the patient and the family, we can't provide high quality care. So that is the huge advantage of work of oncology, cancer centers, cardiologists, and others being able to work alongside a palliative care team because they know the palliative care team makes the time, has the time, organizes their schedule to have the time, because that's a necessity to ensure quality care for the patient. And what occurred in your cancer center, which was that there was an embedded palliative care team that was there, just like the social workers and the nutritionists and the people who help you with the billing. There's also a palliative care team there. It's a routine part of care for cancer patients, and oncologists rely on it. That is not true in many other serious illnesses, say end-stage kidney disease on dialysis, or people with emphysema, people with heart disease, people with neurology problems like dementia or stroke. We're way behind in those diseases in terms of giving what you got, because in a way you were lucky enough to have cancer, a disease where it is common to integrate palliative care into the routine care of cancer patients.
So listening to what you just said, so it's fair to say not everyone's going to need a neurologist or a cardiologist or an oncologist, but at some point in everybody's life, we're going to need palliative care.
At some point in everybody's life, we're going to have a serious illness.
Right.
It's just the contract you sign when you're born. You're born, right. You grow up, you get older, you live your life, and as we age, our risk of developing one or more serious illnesses eventually becomes 100%. And what we have to understand is that we want to live with those serious illnesses and function and have an acceptable quality of life. We can't eliminate all illness from the planet. It's just not possible. But we can do a great deal better at helping people have a longer life and a life worth living during that serious illness. And I think that's been easier for doctors and others to see in cancer because patients with cancer have not only side effects and symptoms from the cancer itself, but very much from its treatment as well. And
Right.
there's recognition that the treatment causes suffering, and that the ability to reduce and prevent that is essential. There's less recognition of that in, say, for example, Alzheimer's disease,
Right.
or heart disease or kidney disease, yet the suffering is the same. I mean, it's not identical, but there's a lot of it. And addressing that, being heard, having family members get the support they urgently need is just as important in any kind of serious illness as it is in cancer.
So how does this push out? What does that look like for you to get this out to other branches of medicine?
So that's what I spend my day obsessing about, Rae Anne. How do we get this to be the standard of care? How do we get this to be the routine that every patient and family can expect? That you were lucky. You were lucky that you went to a cancer center that had these services. It shouldn't be about luck. It should be the standard of care. It should be reliably present for anyone, any patient, and any loved one helping that patient go through a serious illness. So what's it going to take for that?
Any
Exactly.
demographic, it should just be there.
Right, it should just be there. So for example, we know when we go to an office or a nursing home or a hospital, there will be nurses there. There are always nurses there. That's a key element of quality care. If there were no nurses, the place would shut down.
Right.
We want palliative care to be viewed the same way. It's just an essential foundation for taking care of people with serious illness. So how do we get there? That's the question. And some of it has to do with changing policy, changing what our senators and our Congress people and Medicare decide are the basic quality requirements. That if you want to get paid by Medicare or commercial insurance, you must provide nurses, for example. We want those rules to also say you must provide palliative care that meets certain quality standards, and we're not there yet. So that is a process of educating our elected representatives and the people who work at Medicare and other insurers about the essential nature of palliative care. The other process that's necessary is educating the public, and this is why I'm so grateful to you for doing this with me, because your story is so, A, it's so typical, and B, it's so compelling that why wouldn't I get that kind of care? And what I hope is that the people who hear you and us talking will say to their doctor, you know, I heard this video about the benefits of palliative care during a serious illness, helping people get through it, helping their families get through it. I'd like you to refer me for palliative care. And I want that because I understand that it will not only help me feel better and help me survive this difficult period during treatment and adjusting to life with this serious illness, it will help my family. And I'm really concerned about my family and the burden this is putting on them. And if you won't refer me, I'll find resources myself. I'll go to the website that links to programs in our community. And it's important to say that there is a website for patients and families to find palliative care resources, either because they don't exist where you live, because we haven't gotten to where it's everywhere, or because your doctor and team doesn't understand the benefit of it and hasn't made that connection. You can go to a website called getpalliativecare.org, all one word, type in your zip code, type in your city, and you'll get a drop-down menu of all the programs in your region. And you can advocate for yourself. And I think anyone who has been a patient in the US healthcare system knows that you have to advocate for yourself.
Absolutely.
You have to speak up for yourself or your needs will not be met.
Absolutely.
And I think that's hard for patients because we feel like we don't want to bother people and we don't want to intrude on our busy doctors and our busy nurses. But the fact is, the squeaky wheel gets the grease. And this is often the family member that has to be the squeaky wheel. to get the care that both they and their loved one, their patient, need. And finding and getting palliative care is part of that for patients and families.
I remember my sister using that exact term, and she would go out into the waiting room, out into the hallway of the treatment area and say, hold on, I got to squeak, because something was wrong or something was beeping. I wasn't feeling as good as I could be. And that's what she would say, hold on, I've got to squeak. And you're right, the squeaky wheel gets the grease. Unfortunately, that's not always an option for everybody. Not always is there a family that has taken on a patient like, we would want, whether there's distance or, there's just not the family around. Is there options for people who are navigating treatment alone?
So it's a very different situation for patients who are on their own. And as I mentioned, I'm a geriatrician and my specialty is in care of older adults. And because of that specialty, I've taken care of a lot of older people who don't have anyone. Either everyone else has already died, or their kids live 3,000 miles away, or for whatever reason, they've alienated their family, they've been alienated from their family. And there's a name for this in medical practice. It's called the unbefriended patient. So someone who doesn't have a friend, doesn't have family, has no one to rely on. And those are situations that are obviously dramatically more challenging for the patient, as well as for us, the doctors and nurses taking care of that patient. Because we can't turn to that family member and say, make sure he doesn't forget to take that laxative. Right. Make sure that you call if he gets a fever. All those sorts of things, there's no safety net. So right. What we do in a situation like that is turn to our colleagues on the team in social work. And the social workers on both palliative care teams and elsewhere in the health system know about resources that are out there in the community, such as friendly visitor programs. So for example, many faith communities, churches, mosques, synagogues, others have volunteers who serve as friendly visitors for members of their congregation. They call the patient, they check in on the patient, they actually visit several times a week. That's one example of the sorts of things that are available. There are something called area agencies on aging, which are government funded and provide resources for people who are alone, including friendly visitors, volunteers, people who can come and read to the patient, meal delivery, transportation, assurance of helping people find safe housing. And very often that safe housing has staff that can check in on the patient and help monitor the patient. And in some situations when the patient is really, really sick and cannot take care of themselves, we need to find a place for them to live where they can get help. And those are the resources that social workers know about and know how to find. And so I think it's important, if you are alone, living with a serious illness, that you say to your nurse or your physician, I live alone and I don't have help. I wonder if you can help me figure out how to build a support system, because when going through this treatment, living with this illness is going to be tough for me to do on my own. And then your doctor or your nurse will connect you to a social worker who will help you. So it's not something to be ashamed of, and it is true of so many Americans that they are alone, and that's great as long as they're healthy and they can take care of themselves. And many people prefer it that way. But when you need help, you have to ask for it. You have to speak up.
So for people who feel that they don't have a safety net, there is a safety net.
Yes, exactly.
Which is just another wonderful layer of what this specialty has to offer.
Exactly. And people in our field are really determined and persistent, and we don't take no for an answer, and we are determined to find solutions, and we don't give up. So that's kind of our character as a field, that the patient's problem is our problem. And everybody needs that.
Everybody.
Everybody
Oh,
needs
the load is always lighter when it's shared a little bit. And it's nice. It's nice to know that that you're out here and with your team and your people making lives for people like me and going through serious stuff that, life changes on a dime. You didn't, you're walking through one day and bam, you're hit with news that is life changing. And putting pieces of puzzles back together to get life to what it was before your diagnosis. And that you don't become your diagnosis, in no way anymore. And I'm only 4 years post-treatment, or post-diagnosis, not even post-treatment. I in no way associate as a cancer patient anymore. I'm a mom. I'm the executive director of a nonprofit. I am a community member. I'm all the things I was before I was sick. That's just a new layer to my life, So thank you. Thank you for being here and doing what you do and making life better.
And let me turn that around and say thank you for being willing to shine a light on your experience and talk about it openly and make what you have learned, the knowledge, your hard-won knowledge, available to hundreds of thousands of other people out there. You're making a really big difference in people's lives who you will never meet.
Thank you.
So I want to say thank you to you.
What I would like to come out of it from my end of it is to get the clinicians and the government, senators and congressmen to realize that it should not be defined by my zip code, that I received this amazing care, that I am 60 miles from New York City, shouldn't predict my outcome. Right. I should be in the middle of wherever and have the same opportunities. Because coming to New York City isn't an option for everyone, for very few people. Right. So my hope is to continue to do this with you and get it out there to as many people as possible, because I certainly would not be sitting here today if it was not for the treatment that I received. So
we're all human. We have a lot in common, and it shouldn't matter where we live.
Exactly.
We can rely on effective, present, responsive, timely, compassionate care.
Should be the goal.
Yeah.
All right. Thank you. Thank you for your time and your energy and your knowledge and your passion. Your passion just exudes from you. So thank you.
Back at you.